Bismillahirrahmanirrahim. Now this is the 10th session for CVS. So normal cardiac pressures, right-sided pressure in the heart and lower right-sided pressures in the heart are lower than the left-sided pressure due to the lower resistance in the pulmonary vasculature. So the pulmonary capillary wedge pressure is good approximation of left atrial pressure. Okay, so because like suppose the pulmonary capillaries, uh, like suppose this is the heart, the pulmonary arteries they drain into the left atrium, right? And there is a very minor pressure difference between the pulmonary arteries and those of the capillaries which are present behind them. So, and the pressure of the pulmonary arteries is similar to the similar to the left atrium. So, if we measure the pulmonary capillary wedge pressure, we can estimate the left atrial pressure. So, it's a good approximation of the left atrial pressure. Pulmonary capillary wedge pressure is equal to left atrial end diastolic pressure, uh, which is equal to left ventricular end diastolic pressure. So during diastole, the end diastolic pressure of the left atrium is equal to the end diastolic pressure of the left ventricle. In mitral stenosis, the pulmonary capillary wedge pressure will be more than the left ventricular and diastolic pressure because the blood is pooling into the left atrium. So the pulmonary capillary wedge pressure will be higher than the left ventricular and diastolic pressure. The pulmonary capillary wedge pressure is measured by the Swans-Ganz catheter, which looks something like this. So here you can see that this is pulmonary artery catheter waveform. This is right atrium, the right ventricle. So we initially enter this catheter into the right atrium, then we move towards the right ventricle through the tricuspid valve. Then through the pulmonary artery, we enter the, I'm sorry, I just said pulmonary arteries here, right? These are the pulmonary veins which enter the right atrium. I'm sorry, which enter the left atrium. So pulmonary veins enter the left atrium. The pressure in the pulmonary vein is similar to that of the left atrium, and that end diastolic pressure in the left atrium is equal to the end diastolic pressure of the left ventricle. Okay, so then we enter the pulmonary arteries, and then from the pulmonary arteries we go to the pulmonary capillaries and then wedge there. So the pressure in the pulmonary capillaries is noted like this. So in the right atrium, the pressure is like 5 millimeters of mercury. In the right ventricle, the pressure goes to the 25 millimeters of mercury, maximum and minimum 5 millimeters of mercury. Like in the right atrium, the pressure is between 0 to 5 millimeters of mercury. The 0 is diastolic and the 5 is systolic. In the right ventricle, the pressure moves between the 5 millimeters of mercury minimum. Or no, it is like 0 to 25 millimeters of mercury. In pulmonary artery, the pressure varies between 10 to 25 millimeters of mercury, and in the pulmonary artery, the pressure is like near about 10 millimeters of mercury. So in this diagram, they are showing the pressures. In the right atrium, the pressure is less than 5 millimeters of mercury. In the right ventricle is 25 by 5. In the pulmonary artery, 25 by 10. Left atrium it is less than 10. Left ventricle is 120 by 10. And in the aorta is 120 by 80. Okay. Then moving forward, we have the next flow sheet diagram over here. This diagram is showing exercise physiology. Increased muscle activity, stimulation of muscle chemo and mechanoreceptors. Sympathetic outflow will lead to venous constriction and increased preload, increased cardiac contractility and heart rate, and resting muscle and splanchnic vasoconstriction. Okay. Increased muscle activity also directly increases the venous constriction and preload. Then the increased venous constriction and increased preload causes an increase in the cardiac output. The same result is achieved by increasing the cardiac contractility and heart rate. This can also increase the cardiac output, and thus ultimately blood supply to the active muscle is increased. The stimulation of muscle chemo and mechanoreceptor can also cause the resting muscle and splanchnic vasoconstriction. Okay, and that also increases the blood supply to the active muscles. So if the muscle which is resting and the gut, there is vasoconstriction in those areas to push the blood towards the actively moving muscle, and by increased muscle activity, the local metabolite production cause the arteriolar dilation within active muscles, and that also increases the blood supply to the active muscle. Then we have capillary fluid exchange. The oncotic and the hydrostatic pressure are working in equilibrium or balance with each other to maintain the fluid flow out or into the capillaries. Mostly it is net outflow, but let's see. The P is representing the hydrostatic pressure, and pi is representing the oncotic pressure. So the difference between the capillary and the interstitial hydrostatic pressure is, if it is more than the difference between the capillary and interstitial oncotic pressure, which means that the capillary hydrostatic pressure is more than the capillary oncotic pressure, so the fluid will start moving outwards. And if the difference between the net hydrostatic pressure is less than the net oncotic pressure, then the fluid start moving inwards, right? So these are the Starling forces determining the fluid movement through the capillary membrane. The PC is the capillary pressure, which pushes the fluid out of capillary, hydrostatic pressure, which pushes the fluid out of capillaries. The PI is the interstitial fluid pressure, which pushes the fluid into the capillaries. Pi C is the plasma colloid osmotic pressure, which pulls the fluid into the capillaries, and pi I is the interstitial fluid colloid osmotic pressure, which is going to pull the fluid out of the capillaries. Then we have JV, which is the net fluid flow. The equation for that is KF. K is the constant. That is the constant permeability of the capillary to the fluid. Okay, that's not constant. That depends on, that varies from capillary to capillary. Into net hydrostatic pressure minus zeta into net oncotic pressure. Zeta is the permeability of capillary to the protein. Edema means excess fluid outflow into the interstitium, which is commonly caused by either increase in capillary hydrostatic pressure, for example during heart failure, decreased plasma proteins, for example nephrotic syndrome, liver failure, and protein malnutrition, increased capillary permeability, like increasing the KF, for example by the toxin, infections, or burns, and increased interstitial fluid colloid osmotic pressure, that increased pi I, for example lymphatic blockage. There is a Uworld point that venous thrombosis is causing edema, just like congestive heart failure causes edema by increasing the capillary hydrostatic pressure. Another Uworld point is that patient with congestive heart failure and increased central venous pressure, but there is no edema. Why? Due to the increased tissue lymphatic drainage, which can compensate for the moderate central venous pressure elevation to prevent the development of the clinically apparent edema. Third spacing, intracellular fluid, first space about 2/3 of the body fluid. Extracellular fluid is the second space, which is about 1/3 of the body fluid, and these are the only two normal spaces. Any space other than them is a third space. So third space is fluid where it should not be. For example, pleural effusion, ascites, and cerebral edema. Low intravascular volume and high total volume. It occurs in post-op or sepsis. Then we are going to start with the pathology section from here onwards. So first one is hypertension. Hypertension is defined as a systolic blood pressure of more than 140 millimeters of mercury, or diastolic blood pressure of more than 90 millimeters of mercury. Okay. So what is primary hypertension? Hypertension of unknown etiology, like 90% of the cases, is related to increased cardiac output or increased total peripheral resistance. Okay, the risk factors are age, obesity, diabetes, physical inactivity, excessive salt intake, excess alcohol intake, cigarette smoking, family history. And for the family history, there is also genetic predisposition that Afro-Americans are more prone to develop hypertension than Caucasians, and Caucasians are more prone to develop hypertension than Asians. Secondary hypertension. Hypertension due to an identifiable etiology is seen only in 10% of the cases. This is a very important fact, that in most of the situations, the hypertension is primary hypertension, and like 90% of the cases, we don't know the cause of it. If it is associated to some secondary etiology, it is called as secondary hypertension. So, the secondary causes can be renal parenchymal disease. Like if there is renal parenchymal disease, so on the labs we will find deranged RFTs, like there will be elevated serum creatinine, abnormal urinalysis, like there will be proteinuria or red blood cell casts. In the renovascular disease, severe hypertension more than 180 millimeters of mercury systolic or 120 millimeters of mercury diastolic after the age of 55. Possible recurrent flash pulmonary edema or resistant heart failure. Unexplained rise in serum creatinine and abdominal bruit. All of these things, they tell us something about the renovascular disease. Primary aldosteronism, easily provoked hypokalemia, slight hypernatremia, and hypotension with adrenal incidentaloma. So these are telling us about primary aldosteronism. Then pheochromocytoma, paroxysmal elevated blood pressure with tachycardia, pounding headaches, palpitations, diaphoresis, hypotension with an adrenal incidentaloma. Cushing syndrome, central obesity and facial plethora, proximal muscle weakness and abdominal stria, ecchymosis, amenorrhea, and erectile dysfunction, hypertension with adrenal incidentaloma. Uh, okay, then we have hypothyroidism. So hypothyroidism can be caused to hypertension. That's weird. But yeah, that can be caused. That can, yes, that can cause it by the sympathetic increase in heart rate and something. So uh, fatigue, dry skin, cold intolerance, constipation, weight gain, and bradycardia. These are the associated symptoms. Then primary hyperaldosteronism, hypercalcemia, polyuria, and polydipsia, kidney stones, neuropsychiatric presentation like confusion, depression, and psychosis. So these can result in primary hyperparathyroidism. Then coarctation of aorta, differential hypertension with a brachiofemoral pulse delay. Got it. So these can be the secondary etiologies: renal parenchymal disease, renovascular disease, primary aldosteronism, pheochromocytoma, Cushing syndrome, hypothyroidism, primary hyperaldosteronism, and the coarctation of aorta. Then comes the renal artery stenosis etiology. Atherosclerotic narrowing of the renal artery in more than 90% of the cases. Fibromuscular dysplasia can be a cause in younger women. Risk factors are other atherosclerotic diseases, for example, coronary artery disease and carotid stenosis, smoking, diabetes, and hypertension. Presentation: refractory hypertension, recurrent flash pulmonary edema, abdominal bruit, acute kidney injury after initiation of the ACE inhibitors. Pathology: on gross pathology, we will find shrunken atrophic kidneys, microscopically crowded glomeruli, tubular atrophy, and interstitial fibrosis, focal inflammatory infiltrates. Fibromuscular dysplasia. The clinical features of fibromuscular dysplasia: patients to screen. Women aged less than 50 with one of the following: severe or resistant hypertension, onset of hypertension before age of 35, sudden increase in blood pressure from baseline, increase in creatinine more than 0.5 to 1 milligram per deciliter after starting angiotensin converting enzyme inhibitors or angiotensin receptor blockers and without significant effect on the blood pressure, systolic diastolic epigastric bruit. The clinical presentation: resistant hypertension from the renal artery involvement, cerebrovascular fibromuscular dysplasia with symptoms of brain ischemia, for example, amaurosis fugax, Horner syndrome, transient ischemic attacks, or stroke. Non-specific symptoms like headache, pulsatile tinnitus, and dizziness from carotid or vertebral artery involvement can also involve iliac, subclavian, and visceral arteries. On physical examination, there will be a hum or bruit in costovertebral angle due to well-developed collaterals. Right renal is more affected than the left one. Renin and angiotensin increased in secondary hyperaldosteronism. Carotid bruit can also be heard. Angiography, as you can see in this picture, will show a string on beard appearance. Pattern on the renal artery will be seen like this. So then we have hypertensive crisis. Now there's a difference between hypertensive urgency and emergency. Hypertensive urgency, it is severe hypertension more than 180 by 120 millimeters of mercury and there is no evidence of end organ damage. Hypertensive emergency, severe hypertension with end organ damage, acute coronary syndrome, encephalopathy, pulmonary edema, acute kidney injury, intracranial or subarachnoid hemorrhage, aortic dissection, papilledema, retinal hemorrhages or exudates. Hypertension complications: coronary artery disease, left ventricular hypertrophy, heart failure, atrial fibrillation, aortic dissection, aortic aneurysm, stroke, chronic kidney disease, hypertensive neuropathy, and retinopathy. These are all the complications of hypertension. Now let's talk about the signs which are associated with the hyperlipidemias. These are xanthomas, tendinous xanthomas, and corneal arcus. Xanthomas, plaques or nodules composed of lipid-laden histiocytes in the skin, especially the eyelids, which are xanthelasma. Lipid-laden histiocytes, dermal accumulation of the macrophage containing cholesterol and triglycerides. Tendinous xanthoma, that is lipid deposit in the tendon, especially the Achilles tendon. And here we have the corneal arcus, so lipid deposits in the cornea. Common in elderly, that is arcus senalis, but appears earlier in life with hypercholesterolemia. Familial hypercholesterolemia, it is one of the most common autosomal dominant disorders. Cause: mutation in the LDL receptor gene in the liver which clears 70% of LDL in the blood, accelerated atherosclerosis, and early onset coronary artery disease. Arteriosclerosis, literally like the literal word, means hard arteries due to thickening of the blood vessel wall. There are three pathological patterns: atherosclerosis, arteriolosclerosis, and Moncke-Berg medial calcific sclerosis. Arteriolosclerosis, It is narrowing of the small arterioles divided into hyaline and hyperplastic types. Hyaline arteriolosclerosis caused by the protein leakage into the vessel wall, producing vascular thickening. Proteins are seen as pink hyaline on the microscopy. It is a consequence of long-standing benign hypertension or diabetes, results in reduced vessel caliber and with end-organ ischemia, classically produces glomerular scarring, that is arteriolonephrosclerosis, that slowly progresses to chronic renal failure. Like this pinkish material is actually hyaline deposition in the vessel wall. The thick pink ring surrounding the light pink lumen represents the hyaline deposits in the vessel wall, and that can be seen in hypertension and diabetes both. Then we have hyperplastic arteriolosclerosis. I think it is specifically seen in diabetes mellitus. It is hyperplastic arteriolosclerosis, which is more specific to hypertension. It involves thickening of vessel by hyperplasia of smooth muscle, that is onion skin appearance. It is a consequence of malignant hypertension. It results in reduced vessel caliber with end organ ischemia, may lead to fibrinoid necrosis of the vessel wall with hemorrhage, classically causes acute renal failure with characteristic flea-beaten appearance. So the thick arteriole is seen lined by many layers of nucleated cells. What is flea-beaten appearance, by the way? Classically causes acute renal failure with a characteristic flea-beaten appearance. It is something that is happening in the kidneys, which is not depicted in these pictures, but there is a flea-beaten appearance. Okay. Then we have molecular medial calcification. It is the most benign condition of them all. So it is just the calcium deposition in the vessel wall, and there will be hardening of the vessels, right? As you can see, like this is the prominent thing over here to see. Like the vessel is visible on X-ray because of the calcium deposition. So it is calcification of the media of muscular medium-sized arteries, and it is non-obstructive. It is not clinically significant, and it is seen as an incidental finding on X-rays or mammography. Then comes the worst of them all, that is atherosclerosis. So it is because of plaque accumulation in the arterial wall, chronic inflammatory process, and involves the macrophages and T cells. It is a form of arteriolosclerosis caused by the accumulation of lipoproteins, especially the LDL, underlying cause of many diseases, myocardial infarction, stroke, peripheral vascular diseases. Affected arteries are large elastic arteries like aorta, carotid arteries, and iliac arteries. Medium-sized muscular arteries like coronary, popliteal. So abdominal aorta, then comes the coronary, then popliteal and carotid. There was some mnemonic to that, but I don't remember it. So the most common artery to be affected is the abdominal aorta, then comes the coronary arteries, then popliteal artery, and then carotid artery. So this is the sequence. Now let's talk about the risk factors. So there are some modifiable risk factors and then the non-modifiable risk factors. So the modifiable risk factors for atherosclerosis are smoking, hypertension, hyperlipidemia like increased LDLs and diabetes. Non-modifiable risk factors are age, sex more in men and postmenopausal women, and family history. Pathophysiology, endothelial injury or dysfunction. Details incompletely understood, but it starts with the damage to the endothelium because our endothelium is anticoagulant, right? It does not allow the platelets to stick to that. But if it is happening, so like if the platelets have to stick, or if the atheromatous plaque has to form, so first thing that happens is the damage to the endothelium, and how it happens, it is not understood. It is believed to be related to the risk factors: cigarette smoke, high blood pressure, high cholesterol. Common sites of plaque are branch points and the vessel regions. For example, this is abdominal aorta, and then it is giving rise to superior mesenteric artery, for example. This is a good point for atherosclerosis plaque formation. So at the branch points, the blood flow that was streamlined becomes turbulent, and this turbulent blood flow, if is also high in pressure, for example during hypertension, or contains some toxins like the cigarette smoke toxins, so it can cause endothelial damage, and that is why these sites are one of the favorite locations for the formation of atherosclerosis plaque. Lipids, LDL accumulation in intima. LDL is oxidized by the free radicals. Oxidized LDL is scavenged by the macrophages and cannot be degraded. Macrophages become foam cells, and they look like pretty streaks in most of the people. Like most of the people by the age of 10 years have developed fatty streaks in them. Like almost like it may be present in me and almost all the people who are listening to me right now. The chronic inflammation, LDL oxidized from free radicals damages the endothelium, smooth muscle. Macrophages release cytokines, smooth muscle migration. Smooth muscle cells proliferate in the intima lay down the extracellular matrix and they will form fibrous plaques. The key growth factor is a platelet-derived growth factor, the PDGF basically. Atheroma growth. The fatty streaks, they are macrophages which are filled with the lipids, form line, streak along the vessel lumen, and they do not impair the blood flow. Can be seen in children and adolescents, and they may not progress at all. Atherosclerotic plaques, intima will thicken and lipid will accumulate, usually patchy along vessel wall, rarely into entire vessel wall, and usually it is eccentric. So this is endothelium, intima, media, and adventitia. Monocytes and platelets, they are squeezed into the intima through the endothelium. Then formation of fatty streaks happen by when the macrophages they start engulfing the LDLs, the oxidized LDLs basically. Then those macrophages and also some of the smooth muscle cells which have de-differentiated and they come into the intima and they also start engulfing the oxidized LDLs and they also become uniform cells. So form cells and lymphocytes. And fibrofatty theroma, the fibrous cap, fibrous collagen fibers, and lipid debris. The Uworld point is that vascular smooth muscle cells are the only cells within the atherosclerotic plaque that are capable of synthesizing structurally important collagen and other matrix components. Progressive enlargement of the plaque results in remodeling of the extracellular matrix and VSMC death. What is that? Vascular smooth muscle cells death, promoting development of vulnerable plaques and an increased propensity of rupture. So it is not the size which matters. It is basically the strength of the fibrous cap that is important, because if that gets ruptured, the plaque will be exposed and the platelet will stick to that and the artery will be blocked. Yeah, that is one of the most heinous complications of atherosclerosis. Other ones include cystic medial necrosis, which can cause the aneurysm formation, and others. So this is a very good definition, good diagram. So it all starts from here. Like firstly, there will be endothelial dysfunction. LDL will start entering the intima. It will become oxidized by the free radicals. Macrophages will engulf that and they will become form cells. The platelet adhesion will be occurring on the endothelium, which will secrete platelet-derived growth factors. This platelet-derived growth factors will cause the smooth muscles to become de-differentiated, which will come into the mix. They will start eating the LDL and also becoming the form cells, smooth muscle cell proliferation, migration, extracellular debris, and necrosis. Now these things, the collagen synthesis will form a fibrous cap. It is the strength of the fibrous cap which tells us about the stability or instability of the plaque. And if it becomes ruptured, so it can give us a lot of deadly complications. So this is human endothelium, intima, and this is media. Atherosclerotic complications, ischemia, plaque rupture, exposes thrombogenic substance will lead to clot formation. Yeah. So the first complication is ischemia because of the plaque itself. Because if it is a lumen and the lumen is being obstructed, so less flow is moving to the distal tissue, so that can cause ischemia. Then there can be plaque rupture or maybe hemorrhage into the plaque, aneurysm, and dystrophic calcification. These are the complications. The plaque rupture exposes the thrombogenic substances that will lead to clot formation, may cause acute vessel closure, that is STEMI. Thrombus may embolize, stroke from the carotid plaques. Hemorrhage into the plaque can also occur, like bleeding into the plaque. Lesions in the intima cause proliferating small vessels, that is neovascularization. Contained rupture may suddenly expand the lesion. Aneurysm. Lesion may damage the underlying media. Plaque associated with abdominal aortic aneurysm. Dystrophic calcification, commonly seen in atheroma, results from chronic inflammation and basis of coronary CT scans. The Uworld point, the case scenarios, 12 years with flat yellow spots on the inner surface of the aorta. These are fatty streaks, not raised, don't disturb the blood flow, and show intracellular lipid accumulation. Presents in all aortas of all children more than 10 years, and this is a normal finding. Next question is about which cells does provide the major proliferative stimuli for the cellular component of the atherosclerotic plaques. The answer is platelets. Endothelial injury will lead to platelet adhesion. Platelet-derived growth factor, smooth muscle migration from the media to the intima and proliferation. The tissue growth factor lead to interstitial collagen production. Then another Uworld point is vascular reaction to the intimal injury will lead to intimal hyperplasia and fibrosis mediated by the smooth muscle cells that migrate from the media to the intima. Fibrous plaque will lead to intimal plaque and necrotic lipid core with fibromuscular cap. Prostacyclin PGI2 synthesized by the prostacyclin synthase in the capillary endothelium. Function, it inhibits the platelet aggregation and adhesion. vasodilates and increases the vascular permeability and stimulates the leukocyte chemotaxis. Normally, prostacyclin exists in dynamic balance with the thromboxane A2, a prostaglandin that enhances the platelet aggregation and causes vasoconstriction. Prostacyclin and thromboxane A2, normally prostacyclins do not allow the platelets to adhere and also causes vasodilation, and the reverse is done by the thromboxanes A2. Like thromboxane A2 causes the platelet adhesion with vasoconstriction. So normally there is a fine balance between them. Prostacyclin and thromboxane A2 together maintain the capillary patency and normal blood flow. Damaged endothelial cells lose the ability to synthesize the prostacyclin and therefore predisposed to the development of thrombi and hemostasis. Synthetic prostacyclin is used in the treatment of pulmonary hypertension, peripheral vascular disease, and Raynaud phenomena. Aortic aneurysm. As the name indicates, aneurysm is the abnormal dilation of some segment of the artery, and if it is aortic, so it is for the aorta. It can happen at two locations, that is thoracic aortic aneurysm or abdominal aortic aneurysm. Localized pathologic dilation of the aorta, thoracic aneurysm. This one is due to weakness in the aortic wall. Risk factors include hypertension, connective tissue disease, for example, Marfan syndrome, due to the cystic medial degeneration, myxomatous changes in the media of the arteries, bicuspid aortic valve, tertiary sepsis, obliterative endarteritis of the vasa vasorum. It results in a tree bark appearance of the aorta. Major complications: dilation of the aortic valve root, resulting in the aortic valve insufficiency, compression of mediastinal structures like airway and esophagus, and thrombosis and embolism. Abdominal aortic aneurysm usually arises below the renal arteries but above the aortic bifurcation, primarily due to the atherosclerosis classically seen in male smokers more than 60 years old with hypertension. Atherosclerosis increases the diffusion barrier to the media, resulting in atrophy and weakness of the vessel wall. It presents with a pulsatile abdominal mass that grows with time. Major complication is rupture, especially when more than 5 cm in diameter, represented with a triad of hypotension, pulsatile abdominal mass, and flank pain. Other complications include compression of local structures, for example, ureter, and thrombosis and embolism. A Uworld point is that direct cause of abdominal aortic aneurysm, transmural inflammation of the aortic wall. Although atherosclerotic changes are frequently present in the patients with the abdominal aortic aneurysm, they are limited to the inner aortic wall layers. In contrast, abdominal aortic aneurysm are characterized by transmural inflammation of the aortic wall. Chronic inflammation leads to degeneration of elastin and collagen by proteases, resulting in the loss of elastin and smooth muscle cells and abnormal collagen remodeling and cross-linking. These changes lead to weakening of the progressive expansion of the aortic wall, resulting in the aneurysm formation. I would like to read it. Although the atherosclerosis changes are frequently present in the patient with abdominal aortic aneurysm, they are limited to the inner aortic walls. In contrast, abdominal aortic aneurysms are characterized by the transmural inflammation of the aortic wall. Chronic inflammation will lead to degradation of elastin and collagen fibers by the proteases, resulting in the loss of elastin and smooth muscle cells and abnormal collagen remodeling and cross-linking. Okay, these changes lead to weakening and progressive expansion. So basically, it is in abdominal aortic aneurysm, it is the transmural inflammation that is happening because of some reason, and when that happens, there are elastases and there are protein digesting enzymes which are released into the mix, and they will start digesting the elastin and elastin, right, in collagen, and then new collagen will be deposited, but that will not be arranged in a very well manner, so that can cause the weakening of the vessel wall, and thus that balloons out in aneurysm. Then we have aortic dissection, longitudinal intimal tear forming of false lumen. It occurs in proximal 10 cm of the aorta, that is high stress region, with pre-existing weakness of the media. Most common cause is hypertension. Older adults also associated with the inherited defects of the connective tissue. Younger individuals. Hypertension, single most important risk factor. It results in the higher arteriolosclerosis of the vasa vasorum. Decreased flow causes atrophy of the media. Then we have Marfan syndrome and Ehlers-Danlos syndrome, classically lead to the weakness of the connective tissue in the media, cystic medial necrosis. Presents aortic dissection means, like, suppose this is the blood vessel, and inside that we have the lumen, right? This is the lumen. If the blood starts moving out of the lumen, but between the layers of media, like it is not out extravasating, but it is still moving in between the layers of the blood vessel wall, so that is called as aortic dissection. So the most common cause is hypertension, single most important risk factors. Then Marfan syndrome and Ehlers-Danlos syndrome can lead to the weakening of the connective tissue in the median, and that can also lead to dissection. So the presentation, the complaint that the patient comes to you with are sharp tearing chest pain that radiates to back with or without markedly unequal blood pressure in the arms. Chest X-ray will show mediastinal widening. Complications include pericardial tamponade, most common cause of death, rupture with a fatal hemorrhage, and obstruction of branching arteries, for example, coronary or renal, with the resultant end organ ischemia will be there. Okay, now for the dissection, we have two type of classification: Stanford classification and DeBakey classification. Uh, yeah, so this one is dissecting aortic aneurysm. Okay, so they are not referring to the DeBakey or the Stanford classification, but for the Stanford classification, type A is any type of classification which includes ascending aorta, and if it includes only descending aorta, it is type B. Okay, I don't remember that other classification, the Becky classification, but it was like 1, 2, 3, and let's see that. Just give me a second. So here you can see that the Stanford A classification is anything that involves the ascending aorta. If it involves ascending and descending aorta both, it is DBK 1. If it involves only ascending aorta, it is DBK 2. If it involves descending aorta only, it is Stanford B and DBK 3. It is subdivided into DBK 3A and 3B. If only proximal descending aorta is involved, it is DBK 3A, and if distal descending aorta till the bifurcation of the renal till the bifurcation into the common iliac arteries is also involved, then it is DBK 3B. Now coming back to our discussion, so these two are Stanford type A. Okay. And this one is DBK type 2. This is DBK type 3, and this is DBK type 1. Like if both of them are present, then it is DBK type 1. If only ascending, so DBK type 2, and if only descending, DBK type 3. So Stanford classification, it refers to the aortic dissection that involves any part of ascending aorta. Usually originates in the sinotubular junction. The areas are thought to be predominantly affected due to the increase in the rate of rise of pressure and in shearing forces of these sites in the patient with a severe hypertension. Stanford type B refers to all other dissections involving the descending aorta, typically originate close to the origin of left subclavian artery. Okay, so we have talked about that. This is normal vessel. This is true aneurysm, which is involving all the layers, and then we have false aneurysm, which can be a hematoma because of extravascular because of blood leaking into the extravascular connective tissue. Okay, the clinical features of Ehlers-Danlos syndrome and Marfan syndrome are similar as well as somewhat different. So in Ehlers-Danlos syndrome, the skin is transparent and hyperextensible. There will be easy bruising and poor healing, velvety with atrophy and scarring. In the musculoskeletal system, there will be joint hypermobility, pectus excavatum, scoliosis, high arched palate. The cardiac system will show mitral valve prolapse. Other associations are abdominal and inguinal hernia and uterine prolapse. The genetics is COL5A1 and COL5A2 mutations, and it is also autosomal dominant, Ehlers-Danlos. If you are talking about Marfan syndrome, so there are no skin changes in Marfan syndrome other than stria. Musculoskeletal shows joint hypermobility, pectus excavatum or carinatum, scoliosis, and the person will be tall with long extremities. The cardiac manifestations shows progressive aortic root dilation and mitral valve prolapse. The other manifestations are lens and retinal detachment and spontaneous pneumothorax. Genetics are FBN1 mutation, so there is a mutation in the fibrillin gene 1. This is fibrillin gene, and there are in Ehlers-Danlos syndrome we have mutation in the collagen synthetic pathways, and this one is autosomal dominant too. The next thing is cardiac ischemia. So myocardial ischemia, it can be a stable angina or acute coronary syndrome. Acute coronary syndrome is divided into two, actually it is three. Unstable angina also comes here, but they have classified that under the non-ST elevation ACS. So acute coronary syndrome can be ST elevation myocardial infarction or non-ST elevation acute coronary syndrome. Now, non-ST elevation can be STEMI or unstable angina. So, in the stable angina, you can see that although the plaque is occluding more than 70% of the lumen, but still it has a very thick fibrous core, and this fibrous cap is not has not ruptured. So the only causes of ischemia is the luminal narrowing. But in the case of unstable angina or acute coronary syndrome, the problem is that although the plaque was very thin, like it was just occluding 30% of the lumen, but because of the thin cap, it ruptured, and then there was an occluding thrombus that was formed, and that resulted in acute coronary syndrome. So the likelihood of myocardial infarction is increased with the action of metalloproteinases. These are the collagen digesting enzymes which can be present in the plaque, and they can cause the damage or rupture of the fibrous cap. They degrade the collagen and decrease the plaque stability, and that can lead to plaque rupture. Stable angina. Angina means chest pain due to ischemic myocardium secondary to the coronary artery narrowing or spasm. There is no myocyte necrosis. It results from the myocardial oxygen demand supply mismatch. It manifests as chest pressure, tightness, or pain that is reliably produced by the exertion and relieved by the rest or nitroglycerin. It occurs due to fixed atherosclerotic plaque obstructing more than 70% of the coronary artery lumen that limits the blood flow during exertion. Stable atherosclerotic plaque is characterized by no plaque ulceration, no thrombus, and usually with ST depression on ECG. Acute coronary syndrome. In unstable atheromatous plaque, plaque rupture will lead to thrombus formation. If it is subtotal occlusion, that will result in unstable angina or non-ST elevation myocardial infarction. And in cases of total occlusion, there will be ST elevation myocardial infarction. Characters of unstable atheromatous plaque. If it has a thin fibrous cap, it can ulcerate and rupture and will lead to thrombosis and myocardial infarction. Activated macrophages in atheroma will lead to metalloproteinases, collagen degradation, and that will lead to intimate inflammation and ulceration. Statins decrease this inflammation and are useful in acute coronary syndrome to stabilize the plaque. Rich lipid core cannot go rupture. Then we have unstable angina. So in the cases of unstable angina, thrombosis with incomplete coronary artery occlusion, with or without ST depression and or T-wave inversion on ECG, no cardiac biomarker elevation unlike non-ST elevation myocardial infarction, increase in frequency or intensity of chest pain or any chest pain at rest. Plaque disruption or erosion will lead to thrombus formation with or without embolization. Okay, so that can lead to acute cardiac ischemia. Now we have to differentiate between the ST segment elevation and non-ST elevation. So ST segment elevation, elevated markers of myocardial necrosis, and ST elevation myocardial infarction, Q waves usually present. So there are like classical findings. There will be hyperacute T waves, Q waves, and there was another finding, inverted T waves. Yeah, so hyperacute T waves which eventually get inverted, and there are pathologic Q waves. Okay, so in the non-ST segment elevation, markers of and right bundle branch block can also be present. Markers of myocardial necrosis will not be elevated in. If not elevated, it is angina, and if elevated markers of myocardial necrosis, then non-ST elevation myocardial infarction, Q waves are usually absent in this one. So this is acute coronary syndrome. These three things are acute coronary syndrome. Yes. Okay, then we have the risk factor for coronary heart disease. Highest risk factor coronary heart disease equivalents are non-coronary atherosclerotic disease, diabetes mellitus, and chronic kidney disease. The major risk factors are hypertension, hyperlipidemia, increased LDL and triglycerides, cigarette smoking, advancing age, obesity, and physical inactivity. Extent of ischemia. If it is transmural ischemia, like this one. So in transmural ischemia, the whole wall is thickened. Basically, the current flows towards the ischemic area. Like suppose the electrical activity of the heart is towards this area. Now, if we are placing the probe on that, so this will show because our detector is present over here and current is moving towards this direction. So we find ST elevation. If it is not transmural, so we know that the subendothelial layer is the first layer to get ischemic. So as a rule of thumb that the current moves towards the ischemic area, so current start moving to this direction, our probe is here. So if the current is moving away from our probe, so it will be ST ST segment will not be elevated, right? So that is the thing. So subendocardial ischemia occurs with flow obstruction but some distal flow, stable angina, unstable angina, and instami. Subendocardial ischemia and transmural ischemia. So here you can see that in such situations we find no ST elevation or ST depression, while in this situation we find ST elevation. Vasospastic angina, which is also known as the Prince-Metal or variant angina, it occurs at rest secondary to coronary artery vasospasm. It occurs on midnight or early morning. Sometimes symptoms improve with exertion. That's a good thing. That's a very, because that's a unique thing. Smoking is a risk factor. Hypertension and hypercholesterolemia are not, because it is not caused by the plaque formation. It is caused by the constriction of the coronary arteries. The triggers include cocaine, alcohol, and triptans. And there's a transient ST elevation. On ECG, normal cardiac enzymes ergotamine provocative test is positive. Treat with calcium channel blockers, nitrates, and smoking cessation if applicable. Okay. Then avoid propranolol, which is a non-selective beta blocker and can cause unopposed alpha stimulation, and symptoms may worsen by that. So then we have coronary steal syndrome. We'll give a session till here and we'll continue with the coronary steal syndrome in the next session. Until then, Allah Hafiz, fi amanillah, and take care.